Welcome to Going Antiviral, the podcast for the IAS-USA, a professional continuing medical education organization focused on HIV and other viral diseases. I'm Dr. Michael Saag, professor of medicine and infectious diseases at the University of Alabama at Birmingham and volunteer member of the IAS-USA Board of Directors. Welcome to the Going Antiviral podcast. Today, March 3rd, 2024, we are at the Conference on Retroviruses and Opportunistic Infections, also known as CROI, and we're here with Dr. Ravi Gupta, who led the team that treated Adam, the so-called London patient, through a bone marrow transplant, enabling him to become the second person known to have been cured of HIV. Ravi, welcome to the show.
Thank you very much.
It's great to have you. I'd like to know how you first encountered Adam.
Yeah, this is going back a long time now. I first met Adam through a colleague who was an HIV clinician as well, who had been seeing Adam in the clinic after his diagnosis of lymphoma and who had been looking after his HIV side. And he had essentially been advised that a stem cell transplant from an unrelated donor was the only way to survive the lymphoma. And so the idea had come to light that we might try to find a donor who was negative for or had the delta CCR5 mutation, and in order to replicate the Berlin patient, in other words, to replace his immune system with an immune system that's resistant to HIV. So I was asked to advise on this from the virology point of view, and this is back in, I think, I'm trying to remember now, probably 2015, something like that, yeah. So that's how I was first introduced to Adam, through a colleague in the clinic.
And your background is in virology. Do you also do transplant medicine, oncology as well?
So my background is in infectious diseases as a clinician, and I was particularly interested in HIV/AIDS. I didn't have any experience of transplant, and in fact the Imperial team where Adam was being seen for an unrelated stem cell transplant were in fact the leaders of the transplant procedure, and they were in fact they were the ones who thought that they may be able to find a CCR5 negative donor. So they had done all of that groundwork to plan this, but they're not virologists or infectious disease physicians, so that's where I came in.
So it really did take a village. It took a lot of people with different expertise all pulling together on Adam's behalf to make this happen.
Absolutely. It was a huge team effort from start to finish, and I think that everybody was essential to the outcome, really.
How did they go about the search for the donor for the stem cells?
So in Europe, we have a registry. So the HLA information is there on a database, and so it's relatively straightforward. If you have a patient who needs a transplant, you then go on a search on the database. And fortunately, they have been recording information on CCR5 as well, so you can identify somebody with who's homozygous for the deletion. For the delta.
Mm-hmm. So how were you informed that they had discovered the stem cell donor?
Well, in the beginning, we were on a course to find the donor. So first I was introduced to Adam, and then they said they were going to look. And I don't know how long after, I can't remember now, but it was a few months later they said they had found a donor. And I was pretty surprised because, Adam is we know that CCR5 homozygosity for the deletion is mainly in Northern Europeans. And, Adam has a mixed heritage, I believe. So I was a little bit surprised and of course very pleased, but also kind of anxious, because then this meant that we kind of had to potentially go forward with the experiment, on the HIV cure side.
Right. And so he gets prepped and he has the transplant, and you're there during this time. And are you also consulting with them for any kind of complications of the transplant, like secondary infections that often pop up?
Absolutely. So it was a really intense period. I mean, Adam and I met at least once a week, I think, in the clinic, in the HIV clinic, where we were discussing what was going to happen. When he went for transplant, I remember visiting him in his room just before the whole thing happened, and we had a discussion and tried to stay positive, and it was it was a scary thing for me, and let alone Adam himself. So, I sort of took responsibility to some extent for what was going to happen, and. When it came to the complications, we were advising, for example, on his antiretroviral medication. For a while, I think we were discussing having an NG tube, and there were going to be issues potentially with swallowing and absorption of ARVs. So we got involved in a long discussion about formulations and putting things and crushing them down the tube. So it was quite a challenging time.
Yeah, this is before injectable cabotegravir was available. I guess you would have had access to T20 if you wanted to use that, but that's twice a day and probably too much of a risk for other infections. So you remember what antiretroviral regimen you all used? Was integrase based or?
That's right. It was, from memory, it was dolutegravir, and we did use rilpivirine for a little while, but I think then it was TDF3TC.
Yeah.
Yeah.
And tolerated that, and his viral load stayed suppressed through the procedure. And you're looking for drug-drug interactions, and you're looking for complications in the kidney, I guess, with the tenofovir. And did his kidney function stay normal through the whole process?
From memory, yes. Although there were episodes of sepsis where the kidney function did kind of go off. So I mean, Adam was in hospital for a month, and he certainly had neutropenic sort of febrile illnesses at least 2 or 3 times. CMV, yeah, that's right, and CMV reactivation, EBV reactivation. It had pretty much the whole lot.
Gamut.
Fortunately, the GVHD, graft versus host disease, was relatively mild, so that was a good thing.
So it was a good match.
Yes, it was a 9 out of 10 match.
That's pretty good. So as you're going through this, and it's kind of a day-to-day thing, and you're watching him improve, how were you thinking about the timing of withdrawal of the antiretroviral therapy to see if this indeed was a eradication of his virus?
Yeah. So during the hospitalization, of course, when he was ill, it was difficult to even conceive of that. But once Adam was home, we then had the problems of reactivation. So he was home, but he was still getting fevers, and he wasn't, he was still unwell. So again, at that point, we were just hoping to maintain viral suppression with the ARVs, which we did. Adam managed to take his medication as well as many other pills at that time at home. So I think maybe 6 months after he was at home, we started talking about when we would do a treatment interruption. And if you cast your minds back then, there weren't many instances of treatment interruption in the literature. There had been some acute infection studies with ATI. There was, of course, the concern and the observation that some people got an acute syndrome of HIV when they interrupted. So all of these things, we had to discuss them, and saying, look, you could get sick, you could get a rebound, you could get drug resistance potentially when we try to interrupt treatment. And it did take quite a few months for you to decide to do it. It was at least, I think, 4 months of deliberation. And that's after we had done reservoir studies to suggest that the level of HIV DNA and replication-competent virus was below detection limits.
So Timothy Ray Brown, by that point in time, had already moved to San Francisco. I'm pretty sure Steve Deeks was involved in his follow-up and his care. Did you consult with any of the docs who took care of Tim Brown?
Yes, we did. In fact, we had been discussing things with the iSystem Consortium. So, and we did reach out to Steve during the process, because there were a few questions. For example, how if we were going to do the ATI, we needed ethics. So we needed to kind of have the ethical approval, which we did. But within that, we had to kind of state what our mitigations were going to be. How often do we do a viral load? So we kind of settled on every 2 days, out of pretty much a guess. Mm-hmm. And then we had to figure out after 1 month what we would do. So we tapered down the monitoring, but with no real evidence base behind it. So we took advice on various things like that.
Right. In my experience, we had been among the first to use viral load in 1993, and we were exploring how to optimally measure. And so we started off almost daily and then weekly, and watched suppression happen, but then if you withdraw the rebound, and we did see quite a few people with acute retroviral syndrome as the virus came back, especially if they had been treated early in the course. So I think all of your concerns are very well founded. So you finally get to the day where we're going to stop taking the medicine. And what was that like for you, Ravi?
Well, yes, it was. I mean, every time Adam said he didn't want to stop treatment, I was kind of relieved because that was, kind of delaying the anxiety of him coming off the treatment. So, but Adam chose a special day to do the interruption, and it was exciting, but obviously it was the begin. We knew this was going to be just the beginning of another journey, right? We'd already been through all of this transplant, pre-transplant, transplant, post-transplant. Now we were going to enter another phase of intensive monitoring, and it was going to involve real buy-in from Adam to kind of keep coming back to the clinic for the testing. It was going to involve, require a lot of commitment from a lot of people. So, but there was certainly a lot of anxiety because we knew that many people, I think there had been failed attempts at doing this since the Berlin patient, and the Berlin patient, was nearly 10 years, prior to this. So there was well-founded anxiety, I think.
Right, and the prior transplants that had not worked, I think uniformly did not have the Delta 32 stem cell transplant. So I think that was what was different for both Adam and for Timothy Ray Brown. Yeah.
And there was there's certainly one transplant where X4 virus emerged, which was interesting. Despite using a Delta 35 donor, the X4 virus was there at low frequency.
So what did you, you passed over this, but I want to go back and revisit. What assessments did you guys do to look at reservoir?
So we did reactivation studies. So we took, in contrast to other studies, we didn't have ethics to take large volumes, like for example, leukapheresis. So we had to make do with taking 50 ml samples and store it, and obviously separating PBMC and storing them. And so when we did reservoir measurements, we did pooled analyses so we could increase the total number. In fact, so we did latency reactivation studies where you essentially do dilution, limiting dilution of the cells in a plate, and use IL-2 to stimulate the CD4 T cells, and then you detect virus in supernatants, essentially. That was done in collaboration with colleagues in Cambridge. We were at UCL at the time. So they had a nice high-throughput assay where they were using certain feeder cells to amplify the virus once it came out. We didn't find any detectable virus in that assay. And then HIV DNA assays were also used in collaboration with ICSTEM and single copy assays as well.
Did any of those tests turn positive? Was a DNA test positive from the cells that you pooled? So
we did sort of testing at numerous time points, and some of the early assays were all negative. We did get the occasional isolated signal in some replicates for HIV gag, but it was a very small minority.
Just fragments.
Yeah, that's right. And in fact, when we then managed to do some lymph node sampling from the gut, axillary lymph node sampling, I believe.
The faucets up here.
Yeah, and some gut samples, and in those we found isolated evidence of isolated fragments, but no full-length DNA.
Right. Did you use in situ hybridization, or?
We did not use we did not use in situ hybridization or FISH. I don't think on those tissue samples. We tried it, but the specimens weren't high enough quality, so we were left with doing HIV DNA assays.
PCR.
That's right, and colleagues in Oxford also assisted with that. John Frater's team in particular.
So let's fast forward. Continuously monitor the bloodstream, and there's no signal. At what point did you feel comfortable saying, I think we got this?
Yeah, that's a really interesting question because, of course, we monitored for so many months. And I should say in the beginning, we were using lab assays, but then we also used this assay called SAMBA, which is a point-of-care isothermal amplification test for Adam, where we just used a finger prick of blood. So that kind of helped the whole process. And I think after a year, we kind of started thinking, after 12 months, I think that was a that was kind of milestone, isn't it? We had a little celebration. I don't think there was a big party, but we had a kind of private celebration that we'd managed to do a year after the interruption. And then at that stage started thinking this could be real, but then it was a question of waiting. I think that the Berlin patient had been reported at 18 months potentially post ATI. So we kind of used that as a marker for where we needed to be. But we started talking about it and suggesting a sort of presentation based on the data slightly ahead of that time. But I think by the time we presented it here at CROI, it was around 18 months post-interruption.
And as I discussed with Adam, he's doing well, he's happy. Limitations in terms of chronic immunosuppression because of the transplant, but no antiretroviral therapy and doing well. What do you think the lessons are from the experience you had scientifically?
So scientifically, I mean, it was important that this happened, and I think that's why it received quite a lot of attention. It's because of the time period between the Berlin patient and Adam's case. So, at some level, people were getting a bit sort of skeptical as to what actually happened in the Berlin patient. Why couldn't we reproduce it? He had, of course, quite radical treatment, such as not only 1 round but 2 rounds of chemo. Yeah. He had total body radiation. And Adam had neither of those things. So I think it was important to show that you didn't need radiation or more than 1 cycle. He also had anti-CD52 therapy instead of anti-thymocyte globulin, which is slightly cleaner, but as we found out, had kind of longer-term effects on his CD4 count, actually. It was slow to recover. So we learned a few things about the kind of regimens, the potency, whether you needed two or 1 round of chemo. So there were some important scientific lessons, I think. And the fact that we could still observe fragments of HIV was, to me, reassuring, actually, because if you couldn't find anything anywhere and you knew about HIV biology and he'd been infected for so many years, you would be skeptical as to why you couldn't find the stuff, suggesting your assays weren't good enough, maybe. So the fact that we found fragments was also scientifically quite important.
Yeah. So to wrap up, a lot of patients, maybe people with HIV, may be listening to this and they hear the word cure and they think, oh, I want to do that. What's your commentary to folks who don't have another reason for a transplant to seek out a transplant to cure themselves of HIV?
Yes, this was one of the sort of implications or of what happened is that many people kind of glossed over the transplant side and thought there's a cure and I'd like it. So we had a lot of people writing in. But of course, Adam went through an experience that had a 10% mortality rate. So 1 in 10 people who have a stem cell transplant such as his, will end up not surviving. So of course, there's a huge risk there. What was surprising to me is I had people writing in saying they were prepared to take that risk. It just tells you how much the stigma has affected people around the world.
Yes.
That they're still prepared to do these risky things to be cured. But of course, the message is the HIV therapy is fantastic, and you can remain suppressed and lead a normal, healthy life. So that was the message to the majority of people. But as I say, that's not enough for certain people who are experiencing stigma.
Well, thank you very much for joining us, Ravi. Congratulations to both of you for a wonderful outcome this far and for the public acknowledgement of the sort of miracle of science, but also this partnership between a patient and the provider and the scientist to all come together and have this wonderful outcome. Congratulations to all of you.
Thank you. It was a great privilege working with Adam, and I think that's right, that this interaction has been really quite special. I'm not sure that it's happened in many other spheres, so I'm certainly very fortunate to have known Adam.
Indeed. Thanks again.
Thank you.
Thank you for listening to this episode of Going Antiviral. Catch up on earlier episodes wherever you listen to podcasts, and check out the video versions of this episode and others on the IAS-USA YouTube channel. You can find these links in the show notes, or simply go to YouTube and search for IAS-USA, and there they are. Be sure to subscribe, rate, and review Going Antiviral on Apple Podcasts. This podcast is for informational and educational purposes only and is not intended to serve as medical advice. Opinions expressed in this podcast do not necessarily reflect the opinions of the IAS-USA or its affiliates. If you have a question you'd like answered on the show, you can send it to podcast@iasusa.org to be answered in a future episode.